My name is Juan Kim, and I'm an Associate Professor of Neurosurgery at UCLA. And today I'm going to speak on posterior fossa tumors. I'd like to thank the CNS for inviting me to give this lecture in the Neurosurgery 100 series. These are my disclosures. So this is a brief overview of my talk. These are some of the more commonly found posterior fossa tumors. Now, there's an obvious absence of vestibular schwannomas and meningiomas, but I feel like those can be a topic of their own. But I feel like these are some of the ones that are found in similar age groups or that they look similar on imaging, and hopefully through this talk I can help you develop a very quick differential diagnosis to narrow down what you might be seeing. In addition to that, I'll go over some surgical considerations and management considerations. As far as these posterior fossa tumors go, I feel like the most important thing as far as figuring out what type of tumor you're seeing on the MRI is the patient's age. There are tumors that are classically found more in pediatric patients versus those that are more commonly found in adult patients. Once you have that, the relationship to the fourth ventricle, I feel, is critical. Is it truly coming from the floor of the fourth ventricle, or is it coming from the roof? And then from there, if it's a parenchymal tumor, is there a mural nodule with a cystic component? And then finally, the patterns of enhancement. The first tumor type that I'd like to speak on are medulloblastomas. Now, medulloblastomas are considered WHO grade 4 tumors, and they're defined by both histologic and molecular subtypes. 75% of patients are younger than 10 years old, and they comprise 20% of all pediatric brain tumors. Now, these were traditionally defined by histologic criteria: the classic desmoplastic and nodular, the MBENs or medulloblastomas with extensive nodularity, and the large cell/anaplastic ones. In the 2021 WHO criteria, they were further defined by molecular subtypes. So we have the wingless or Wnt activated, the sonic hedgehog activated ones, which are further subdivided by the presence of a TP53 mutation, and the non-Wnt and non-sonic hedgehog subtypes, which were previously called group 3 and group 4. Now, with both the histology and the molecular subtypes, this allows us to come to an integrated diagnosis that take both into consideration. The Wnt tumors, although they comprise a small subset of the medulloblastomas, have the best prognosis. Some of this is thought to be due to the fact that they're rarely metastatic on diagnosis. In addition to that, they ostensibly don't have much of a blood-brain barrier, and as such, chemotherapeutic agents and other treatment agents can penetrate them more readily. The group 3s and group 4s, or the non-Wnt, non-sonic hedgehog subtypes, unfortunately have the poorest prognosis, and some of this is due to the very frequent presence of metastases on diagnosis, in addition to some of the genetic mutations of these tumors. Medulloblastomas are embryonal tumors that come from the embryonal rhombic lip. Now, there are two major places where this embryologic structure resides. One is the ventricular zone, which abuts the fourth ventricle, kind of closer towards the lateral aspect, and this is common for Wnt tumors to originate from here. The external granular layer, which is outside the cerebellum, kind of more towards the cerebellar hemisphere, is a common site of origin for these sonic hedgehog type tumors. The persistent rhombic lip is located just dorsal to the fourth ventricle, and this is a common site of origin for the non-Wnt, non-sonic hedgehog groups. If you look at this nice diagram, it really breaks down the different groups of medulloblastomas, and as mentioned before, the Wnt tumors have very good prognoses, low rates of metastases on diagnoses. The sonic hedgehog groups come from the lateral aspect, as mentioned before. The groups 3s and 4s, they have rates of metastatic disease on diagnosis anywhere from 35 to 40%, which plays a role in their poor prognoses, and these are the molecular alterations of these specific tumors. On imaging, medulloblastomas demonstrate heterogeneous enhancement. Typically on T2, they are iso-intense to hyper-intense. They restrict on diffusion due to their high cellularity, and as mentioned before, because these tumors are coming from the fourth ventricle roof or the parenchyma of the cerebellum, they flatten the fourth ventricle floor rather than appearing to infiltrate them. On the right, these rows of images demonstrate the subtypes of medulloblastomas and their radiographic features very well. We see the Wnt-type tumors coming more from the CP angle aspect of the cerebellum. B's are the sonic hedgehog types that are coming from the more lateral aspect of the cerebellar hemispheres. And the C's and D's are the groups 3s and 4s that are coming from the fourth ventricular roof. This table by Ramaswamy et al. In 2016 really helps break down the major features that make certain subtypes of medulloblastoma higher risk or lower risk. If you look at the Wnt tumors, if you have a Wnt tumor in a patient that is younger than 16 years of age, they have a favorable prognosis. The group 3s and 4s, as noted before, the presence of metastatic disease makes it a high risk or very high risk tumor. In addition to those factors, TP53 mutations as well as MYC and amplifications play a significant role in making these tumors higher risk. An interesting note regarding the extent of resection for medulloblastomas is that before, much of the data supported the more aggressive a resection you can do if you had less than 1.5 centimeters cubed of tumor left over following a resection, the better the prognosis might be. In this era where we know that molecular subtypes in the presence of metastatic disease might drive that prognosis a little bit more, retrospective studies have shown that it might not be as clear that extent of resection plays as significant a role. Postoperatively, adjuvant radiation therapy is strongly recommended, particularly in patients older than 3 years old. If they're younger than 3 years old, there is significant concern for neurocognitive delay following radiation. In addition, posterior fossa syndrome, characterized by cerebellar mutism, ataxia and hypotonia, supranuclear cranial nerve palsies, and emotional lability, is commonly found in pediatric patients following the resection of these tumors, particularly the midline ones. This can happen in 10 to 40% of cases and is thought to be secondary to disruption of the bilateral dentato-thalamocortical pathways. So essentially the pathways connecting the dentate nuclei to the thalamus and cortex. Now the next tumor I'd like to go over are ependymomas. Now these are neuroepithelial tumors that arise from ependymal cells. They are commonly found within the cerebral ventricles and they are intracranially located in 90% of pediatric patients. In adults, the majority are found within the spinal cord, about 65% of them. Tumors that originate in cortical crests within the cortex themselves are rare. Now the WHO in their 2021 classification broke down these tumors into posterior fossa ependymoma A and B. Now PFAs are typically found in infants and children. They are characterized by a gain of 1Q, which portends a poor prognosis. They do not have as much histone H3K27 trimethylation, and they project laterally into the CP angle. These are typically associated with a poor prognosis. PFBs are commonly found in adolescents and adults. They are characterized by increased histone H3K27 trimethylation and are found more commonly within the spinal cord or cerebellar midline. They have a better prognosis than PFAs. On imaging, these demonstrate heterogeneous enhancement. They are T2 iso to hyperintense. They look like they're being squeezed through the foramen of Luschka for larger tumors. And their proximity and infiltration to the fourth ventricular floor and brainstem is disproportionate to the size of these tumors, suggesting the site of origin is really coming from the ependyma in that location. There are two major peaks as far as patient age. Patients from 1 to 5 years old are typically where the PFAs are. There's a smaller peak for these posterior fossa ependymomas for patients in their mid-30s, which are typically the PFBs. From classic WHO criteria, these are typically grade 2s and 3s, but as far as prognosis goes, these are not as important as the molecular subtype. Gross total resection is consistently shown to be the greatest prognosticator. Adjuvant radiation therapy is strongly recommended for posterior fossa ependymoma group A even after a gross total resection, given the poor prognosis. There's some question whether or not this is absolutely necessary in posterior fossa ependymoma Bs. There has been some attempt at reducing dose or bridging with chemotherapy for children younger than 3 years of age, giving the neurocognitive side effects of radiation. However, this has been met with disappointing results. Subependymomas are intraventricular ependymal tumors, most commonly found in the fourth ventricle. These are WHO grade 1s, so resection can be curative, and they're typically found in adults in their 5th or 6th decade of life. Imaging characteristics: on T2, these are hyperintense tumors. On T1, they are hypo to iso-intense, and they have a notable lack of contrast. The way I like to remember them: ependymomas, E, enhancing; subependymomas, sans contrast. As you can see on the image on the right, a very notable lack of contrast. Pilocytic astrocytomas are the most common glioma in children. They comprise 25% of posterior fossa tumors in this demographic. 80% of patients are younger than 20 years of age with a median age of 8. On imaging, they very classically are cerebellar masses with an enhancing mural nodule and a cystic component, and they are WHO grade 1. These posterior fossa pilocytic astrocytomas located within the cerebellum are very commonly found to have this KIAA1549 BRAF fusion. Other common genetic mutations include the NF1, FGFR, and the BRAF V600E mutations. As far as management goes, because they are WHO grade 1, gross total resection can be curative, but in cases where surgical resection cannot be safely achieved, BRAF inhibitors and MEK inhibitors have been tried with pretty promising results. Hemangioblastomas are another type of tumor classically found to have an enhancing mural nodule with a cystic component. However, these are more commonly found in adults. 70% are sporadic, 30% are associated with the von Hippel-Lindau gene or disease, and as mentioned before, these are classically found in adults in their 40s and 60s. These also are WHO grade 1 tumors, so resection can be curative. These are the imaging findings, as mentioned before, classically an enhancing mural nodule with a cystic component. Given the very vascular nature of these tumors, they often have T2 flow voids on imaging. In addition to that, DSA demonstrates a significant tumor blush, and preoperative embolization can be very useful in cases that are going to surgical resection. Now, for completeness sake, metastases. These are typically found in adults with known primary disease, or they can be found concurrently as synchronous metastases at the time of a primary diagnosis. On imaging, these are enhancing, well-circumscribed masses. They can potentially have cystic or necrotic components, and they are often multiple. If you have numerous lesions that are asymptomatic, focused radiation, whole brain radiation, radiation treatment options typically are the treatment of choice. However, if you do have a symptomatic lesion, say for example a large posterior fossa lesion such as this, surgical resection should be strongly considered. Particularly for posterior fossa lesions and large lesions, neoadjuvant or preoperative radiation with SRS or SBRT should be considered in order to help mitigate the risk of leptomeningeal disease. To kind of wrap things up and bring things together, so if you have a lesion, for example, an enhancing nodule with a cyst, if it's a young patient, think pilocytic astrocytoma. If it's an older patient, think hemangioblastoma or metastasis. If you have a fourth ventricular mass, is it enhancing or non-enhancing? If it's enhancing, think ependymoma. If it's non-enhancing, think subependymoma. If it's an enhancing fourth ventricular mass, where is it coming from? Is it coming from the floor of the fourth ventricle, in which case think ependymoma, or is it coming from the roof of the fourth ventricle, in which case think more along the lines of a medulloblastoma? Operative considerations: when operating on these posterior fossa masses, typically we do a suboccipital craniotomy or craniectomy with the patient prone, concord position. For these cases, particularly ones where there is infiltration or close intimal association with the fourth ventricular floor, I like to do cranial nerve monitoring, including cranial nerve 6 and 7 for the facial colliculus, as well as 9, 10, 11, 12 for the inferior aspect of the fourth ventricular floor. You can consider placing a right occipital ventriculostomy to help with CSF relaxation, particularly in cases where there's ventricular megaly or concern for postoperative hydrocephalus. I like to do a midline incision with a fascial cuff at the superior nuchal line to allow for a wider tight fascial closure in these cases. Do burr holes on either side of the keel in order to make sure that you can strip the dura from this midline keel as well as the transverse sinus above, and then do a Y-shaped dural incision. In conclusion, understanding the hallmark radiographic and demographic features can really help you narrow down your differential diagnosis in these posterior fossa tumors. Additionally, molecular subtypes are playing more and more of a significant role in the clinical prognosis of these tumors. Thank you.